this talk. Well, thank you. Thanks to those of you joining us on this talk, and for tuning in, and for anyone who's going to join in the next few minutes as well. And I want to thank the organizers at the Nevada Cancer Coalition and Project ECHO and everyone else who invited me to give this talk today, talking about childhood cancer survivorship, a topic that is close to my heart. I wanted to, why is my slide not advancing? What's happening here? There we go. Assuming that most of the audience joining in would be somewhere in the realm of the primary care department, I wanted to start with a scenario from kind of a primary care perspective. So imagining that you're in your office, you're seeing a new patient who's coming to establish care with a new provider, and let's say it's arbitrarily, let's say it's a 25-year-old young woman, and she reports that she had a history of having been treated for leukemia when she was a child. This is pretty much all you know. She's otherwise currently healthy, and she has no acute concerns. And so the questions are, what does this primary care provider need to know to take best care of this new patient? So a few things that come to mind are, you'd like to know what were the relevant treatment exposures. And how are you going to go about finding out this information if the patient doesn't know, doesn't remember, doesn't have any records? And how are you going to try to track down some of this information, and what level of detail do you want to get? The other, another question you want to know about is, what are the potential late effects? What is this patient at risk for? If she's healthy right now, what are the things you should be thinking about in the future for counseling her? What are the things she needs to know to be aware of, and what should you be on the lookout for? What are the things that you should focus on most in performing a history and physical for this patient who's sitting in front of you now in your office? And what, if any, surveillance testing is needed? Does this patient need any laboratory testing, any imaging testing? And if so, how often? How should this patient be followed? Do you need to see this patient back every year, every month? Does she need a referral to some specialist? Does she need to go to a cancer center? Does she need a referral to an adult oncologist? What's the standard of care? What is expected of you in caring for this patient? So with that sort of thought exercise as a backdrop, I'll say that this is not an uncommon scenario, right? And it's not uncommon because we've had tremendous success in treating childhood cancer over the last several decades. And as we pediatric oncologists are justifiably proud, I think, of pointing out, the overall survival rate for childhood cancers in general is approaching or greater than 80%. That number varies, as you can see, across different sort of broad categories of the major childhood cancer diagnoses. You can also see that the cure rates have been increasing rather steadily for most different diagnoses over time. As you look from the 1970s to, this graph only goes up to 2003, but I can tell you more recent data, most of these lines continue to increase. So that means that there are over 375,000, and probably more now because this data is a little bit outdated, childhood cancer survivors living in the United States today. And that translates to 1 in 640 adults up to the age of 40. So yeah, primary care providers will see childhood cancer survivors in their clinical practice. So that's the good news. But all of this successful treatment comes at a cost. And so I'm going to spend the next bunch of this talk talking about some of those costs. Studies have shown that 2/3 of childhood cancer survivors will have some form of chronic late effects of their treatment. And 1/3 of those late effects are not mild, but are severe or may be considered life-threatening. In addition, 1/4 of childhood cancer survivors report having some significant psychosocial problems. 10% report having persistent cancer-related pain years or decades after the end of their treatment and the cancer is gone. The risk of death at 30 years after the time of diagnosis is actually 8 times higher than that in the general population. And the cumulative prevalence of having any chronic medical condition is as high as 95% by the age of 45. Survivors are also 2 to 5 times more likely to report experiencing poor health in general, mental health concerns, limitations in their activity, and functional impairment. So as we think about classifying these things that we call broadly late effects, they can fall into categories broadly as medical and psychosocial. And some of the medical late effects we would think about focusing on include second malignancies, rather importantly, organ dysfunction, including cardiac or pulmonary dysfunction, renal dysfunction. Pretty much any organ system you can think of is at some risk depending on the cancer that was treated and the treatments that were used. Infertility and other endocrine disorders, as well as obesity and diabetes, musculoskeletal and physical defects, and impaired growth, particularly of importance in the realm of childhood cancer as opposed to adult malignancies. Neurologic problems, also particularly important in childhood cancer, especially among central nervous system tumors, but not limited to those groups of patients. Chronic pain, and as I mentioned in that last slide, early death. And there's a similarly large list of psychosocial problems patients are at risk for, including cognitive dysfunction, depression, anxiety, PTSD, low self-esteem, academic problems, unemployment, time off work, financial toxicity, and the list kind of goes on. And I'll get into a little bit more detail as we move on. So how do we know what we know? What kind of research has been done? And a lot in studying late effects of childhood cancer, a lot of the data I'm going to present to you in this study comes from something called the Childhood Cancer Survivor Study, or the CCSS. This is the largest and the most studied cohort of childhood cancer survivors, including over 14,000 survivors who were less than 21 when they were diagnosed. These are patients who were treated in the 1970s and the first half of the 1980s, and by definition had to have survived at least 5 years from their diagnosis. And these patients were treated at 26 participating centers across the US and Canada, with a range of diagnoses representing broadly a lot of what we see in the world of pediatric oncology. This list isn't exhaustive. It doesn't include every diagnosis of what we see in pediatric oncology, but it's a pretty good representation in general of what we see in clinical practice. The database includes a lot of detail of the diagnosis and the treatment details that the patient received. Subjects receive and fill out an extensive health questionnaire at the time of enrollment. And in addition, a random sampling of some of the nearest age living siblings who were not affected by cancer were included for some of the important comparisons in these studies. In addition, the cohort was expanded up to patients treated up through 1999. And patients also receive a series of follow-up questionnaires to ask additional questions that maybe weren't thought of at the time of the original cohort. Now, the CCSS isn't the be-all and end-all. There are other people studying late effects as well, including the Children's Oncology Group, which is the major cooperative study group conducting clinical treatments, clinical trials in childhood cancer across North America. St. Jude's has a very large and robust study population of childhood cancer survivors, and there's a lot of others in the United States and outside the United States too. But the CCSS provides a lot of really good sort of 30,000-foot level kind of data that lends itself well to a kind of overview talk like this one. So a lot of this data comes from CCSS. One of the more kind of shocking bits of information that I alluded to in a previous slide concerns early mortality. I was a little surprised to read about this, that the mortality rate at 30 years from the time of diagnosis for these patients who by definition survived their cancer, they survived at least 5 years from the time of diagnosis, was still as high as 18% when you go out as far as 30 years from diagnosis. So you can see here in this graph, the yellow line is the United States population measured over 30 years. And then here is the CCSS population. And I'll point out that this scale doesn't go from 1, right, this is 100%, doesn't go from 1 down to 0. This is from 1 down to 80%. So it's not quite as bad as it might look at first glance, but it's still bad enough to look at this drop-off for the childhood cancer survivors. So what are these survivors actually dying of? The major cause of death, even though these are people who survived 5 years, is still recurrence or progression of the original disease in almost 60%. Most of that is occurring in the first, in this early phase of this drop-off. But outside of those patients, the next most significant, the next largest cause of death in these patients is subsequent or second neoplasm in over 18%. And the next cause after that is cardiovascular disease in almost 7%. But as I mentioned, there's a transition in the cause of death over time, with the earlier deaths largely being due to recurrence. Risk factors that were identified in this study for second malignancy include patients who were exposed to radiation therapy, as well as certain categories of chemotherapy like alkylating agents and etoposide. And the risk factors for cardiovascular death, which are sort of intuitive and not surprising to those of us who practice pediatric oncology, include patients who got cardiac radiation and those who got higher doses of anthracycline chemotherapy agents. There's a bit of good news buried in here if you look at some more recent publications. So I mentioned the additional cohort of patients in the CCSS treated up through the 1990s. And if you look at these patients again, and you're looking now at the 15-year time point from diagnoses, because those treated in the 1990s haven't had 30 years since diagnosis yet, it's too early. So we're looking at 15 years instead. And you can see in comparing the 1970s here in blue to patients treated in the 80s in red to those treated in the 90s in green here at the 15-year mark, there's been a substantial reduction in the mortality rate, basically cutting it in half from 12% in the patients treated in the 70s down to 6% among patients treated in the 90s. And part of that in this B graph here comes from a reduction in the rate of death from recurrence or progression of disease. That is, our treatments have gotten more effective in curing these patients over time. But there's also been a reduction in mortality from second malignancies, as well as from cardiac and pulmonary causes, mainly associated with reductions in the use of radiation, both the doses and the numbers of patients who receive radiation at all, and reductions in the doses of anthracycline exposures over time. If we shift our focus now from mortality to talk about morbidity and chronic disease generally, I mentioned this number in a previous slide, that survivors are 2.5 times more likely than age-matched sibling controls who didn't have cancer to report in general having some adverse or poor health. Those numbers look like this: 11% of the survivors versus 5% of their siblings report not being in very good health. And this is at an age, this is at a relatively young age, right? At an age of 27 years on average. They're also 3 times more likely to report having limitations in their activity and 5 times more likely to report functional impairment. And if we dig a little bit deeper, 62% of survivors report having at least one chronic health condition, again at an age of about 27 years. 27% of those are not just mild conditions, but severe, life-threatening conditions. And almost a quarter of the survivors report having at least 3 separate health conditions. The relative risk for having a chronic disease is over 3 times that of their age-matched sibling controls, and that number is 8 times higher when we consider only more severe grade 3 and grade 4 conditions. The cumulative incidence at 30 years from diagnosis is as high as 73% for having some form of chronic disease. And again, if you restrict that to just more severe forms of chronic disease, that number is still as high as 42%. If we break it down a little bit, this chart shows you a few different categories of certain, and here we're talking about just the more severe, grade 3 and grade 4, disabling health conditions among the survivors in this column versus their siblings in this column. So there's about 10,000 survivors here, about 3,000 healthy sibling controls. And here's what the numbers look like. If you look at, for example, major joint replacement, 1.6% of the survivors had a major joint replacement. 1.2% report having congestive heart failure. 2.3% had a second malignant neoplasm. And at first glance, these numbers are not exceptionally sort of dramatically high, but compare them to the rate in their siblings who are pretty close in age. No number in this column even approaches 1%, except for ovarian failure here, which is almost 1%. So the relative risk here, comparing the survivors to their siblings, is 54 times higher for having a major joint replacement. It's 15 times higher for having congestive heart failure or having a second malignancy for the survivors as compared with their siblings. And these numbers sort of continue along that vein if you look at these different categories. This table...
Dr. Raphael, sorry, if I could interrupt you quickly. We have one question and a comment in the chat box. So the question is, how long does a pediatric hematologist oncologist follow their patients after treatment?
That's a great question, and it doesn't have a great answer because, well, the answer is it depends. I can speak to my practice or the practice here in Oakland, which may vary across different centers. We tend to get pretty attached to our patients. You know, we see them grow up. We often diagnose them at a relatively young age. And so we like to follow them, and I tend to follow them without sort of having a strict cutoff. Some of these things depend on practical matters, how long their insurance will allow them to keep seeing their pediatric oncologist. Sometimes these patients move away as they go to college or their families move or they get a job or whatever. And it also may depend on the type of treatment center. So we're a children's hospital here in Oakland. So we can't necessarily, we're not all that well equipped to continue seeing patients into their 40s and 50s and so forth. Other treatment centers do have sort of right down the hall or in the same building have an adult cancer center, and so they may make a transition. So the answer really kind of depends on the setup, but we tend to have a transition at some point for our patients. And I'm going to get into the details of how our survivorship program works a little bit later in this talk and how it fits into our cancer program here in general. So let me table the details of that question until I get to that a few slides on, if that's okay.
Yeah, no problem. And then a comment here from Dr. Robin Palmer. If hereditary cancer syndrome, there's a high risk for multiple new cancers. 2.38 second malignancy is a big red flag for hereditary cancer.
That that's an excellent point, and it's true. It's probably been under-recognized over the years. There's a relatively recent publication from New England Journal, sort of showing that the higher than we previously thought or expected rate of inherited cancer syndromes in childhood cancer survivors. So taking a good family cancer history is an important thing to do in the context of a survivorship program and in seeing these patients. You don't always get all the details because people don't always know their family history, and family history isn't always a perfect predictor, but we don't always get to know to interrogate the genetics of these patients in a really robust way. We're doing it more and more, but we don't always have the resources. Insurance don't always let us sort of go through and check P53 status or these kinds of things in every patient, but it's an area of increasing study and something that we're looking at more and more. So yeah, that's a very excellent point and an important part to keep in mind in this context.
Excellent, thank you. That's it for now.
All right. So moving on, looking at this sort of busy slide, it just is meant to sort of bring home the point that the risk of late effects is not necessarily identical across all different forms of childhood cancer. So it's going to vary across different categories of childhood cancer and with the different treatment exposures, which I'll talk more about in detail a little bit later on. But what you can see here in this graph, where the blue lines represent the cumulative incidence of all grades of morbidity and chronic disease, and the red line here is the more severe grades. If you focus just here on the more severe grades, you can see some differences in the relatively lower incidence of more severe chronic disease among categories like leukemia, for example, and non-Hodgkin's lymphoma, compared with central nervous system tumors, Hodgkin's disease, and look at how high it is for bone tumors and for neuroblastoma and soft tissue sarcomas. So not all cancer diagnoses are created equal as far as the risk of having significant late effects in chronic disease. There's, again, a bit of good news here as we look at some more updated data in the CCSS cohort, again, as we look at those treated in the 90s, here in blue, compared with the 80s in red and the 1970s in green, that we've seen a reduction in the 20-year here incidence of grade 3 to 5 chronic health conditions for the more recently treated patients, down to 27% in the 1990s cohort versus as high as 33% in the older cohort. Although, again, there's still a pretty dramatic difference when you look at the incidence in their healthy siblings, which is still only approaching 5% in the purple line down here. Some of this comes from a decreased incidence in endocrine disorders, second malignancies, musculoskeletal and gastrointestinal late effects. But I'll also point out that we find a higher incidence of late effects in certain diagnoses for patients treated in the 90s compared with those treated earlier. And that comes as a result of increased treatment intensity that has been necessary in certain diagnoses like medulloblastoma and neuroblastoma, and that's been necessary to improve survival over time. But as I say, it's come at a cost with increased chronic health conditions. Focusing a little bit on a couple of these important categories, second malignant neoplasms as one of the most important causes of morbidity and mortality in these survivors. The incidence of second neoplasm at 20 to 30 years from diagnosis ranges from 3.2 up to almost 8%, which is 6 times higher than that in the general population at a similar age. There is a 43-fold increased risk of breast cancer in patients who received radiation to the chest. That number is still, though, 4 times higher in patients who did not get radiation at all but received chemotherapy alone. There's similarly a 3.5-fold increased risk of receiving developing sarcoma after being treated with anthracycline chemotherapy. If you look at patients at an older age group, at age 40 to 55, the incidence of second neoplasm is 16.3%. That's down to 2.2 times higher than the general population at the same age group because as you get older, of course, the background incidence of cancer increases. And I'll point out that a big chunk of these second neoplasms are comprised of non-melanoma skin cancers. So that's this sort of reddish line in this graph that's a little bit difficult to read. Cardiovascular disease is another important category worth spending another minute or two on because it's the leading cause of non-cancer morbidity and mortality in cancer survivors. The risk of cardiovascular disease is 8 times higher than that of age-matched sibling controls. The risk factors that we understand very well include anthracycline chemotherapies, that is doxorubicin, daunorubicin, epirubicin, and mitoxantrone, and also radiation. And dose is important. The risk clearly goes up with increasing dose, cumulative dose of anthracyclines received, as well as with the dose of radiation. And these effects are additive. So if you get anthracycline plus radiation, as patients with Hodgkin's lymphoma frequently do, the risk increases. And these graphs here I believe reflect the risk over time and, with exposure to radiation. Over 50%, if you look close enough in various ways, may have subclinical signs of damage to the myocardium within 5 to 10 years, although not all of those patients will go on to develop overt clinical signs of cardiovascular disease. Another important topic worth sort of calling out here is infertility, particularly important in looking at childhood and adolescent cancers, because by definition, this is a group of patients who haven't had the opportunity to have had their own children as opposed to older adult cancer survivors at the time of diagnosis and treatment. So data from the CCSS and others show that survivors are less likely than their siblings in general, across the board, to have been pregnant or to have sired a pregnancy. This is the language that they use, which is interesting to me, but anyway, at a rate of 38% versus 62%, again, for their age-matched sibling controls. Risk factors include radiation, both to the central nervous system, to the head, and also alkylating agents in high doses like cyclophosphamide. Male fertility, it turns out, is more sensitive to the effects of chemotherapy than female fertility is. So if you look at male survivors, almost 50% report infertility compared with 17% for their non-cancer affected brothers. 37% report having fathered a child versus almost 70% of their siblings. If you look at females in comparison, females are 1.5 times more likely to report infertility than their siblings. 2/3 of them, interestingly, did achieve a pregnancy at some point, but they reported a longer time to get pregnant compared with their siblings. It's also important to point out that almost 11% of female survivors report premature ovarian failure. So this is another group who by definition will have infertility, but also will have other problems. At a young age, they may need hormone therapy just to have normal pubertal development, and may continue to need hormone replacement therapy for bone health and other things. And this is at a median age of 31.7%, 24 years from diagnosis, reporting a history of ovarian failure. Clearly, this relates to certain risk factors and treatment groups, depending on their diagnosis. So that's not all, of course. There's a lot of other categories of late effects that I don't even close to have time to talk about in the context of this talk. So I just highlighted a few headline articles from various publications, from CCSS and others, to just give you a sense of the flavor of different kinds of things and issue a few kind of bullet points about. So this publication was a review of selected musculoskeletal late effects in survivors of childhood cancer. This is an important, and I'll pair this with this, functional performance limitations in childhood cancer survivors. Important in, as you can imagine, bone and soft tissue sarcoma survivors who may need a limb salvage procedure or be subject to amputation or the effects of radiation therapy affecting their limbs. But it's also important in survivors of leukemia and some lymphomas, or patients who had bone marrow transplant and needed a lot of corticosteroids in their treatment. And the effects of steroids on bone health can be quite profound and lead to long-term effects. Chronic pain, similarly, often affecting patients with a lot of those same musculoskeletal late effects and those same kinds of diagnoses. Endocrine abnormalities in survivors of childhood cancer are of major importance, especially for patients who received high-dose cranial radiation affecting the pituitary gland, but of course not limited to those patients. Obesity and metabolic syndrome seems to be increased in survivors of childhood leukemia for reasons that are still not clearly very well worked out. Probably has something to do with steroid exposure, but it is not at all well understood why this is a thing. Central nervous system complications are a big deal, particularly for patients with central nervous system tumors, where high-dose radiation as well as surgical treatment can have absolutely devastating neurocognitive and other effects, but also patients who received chemotherapy alone. For example, intrathecal therapy for leukemia, and patients who received bone marrow transplantation are at increased risk for a variety of central nervous system complications. But it's not just the central nervous system. Peripheral neuropathy is also an issue where there can be late effects in patients who receive treatment with vincristine and vinblastine. Ocular late effects can affect survivors, obviously for patients who had, for example, a retinoblastoma or a tumor of the eye, or patients who had tumors like rhabdomyosarcoma in the sinuses that may have required radiation therapy, or anyone who received radiation therapy to the head can be at risk for cataracts, as can those patients who received, again, high-dose corticosteroid therapy. Hearing loss can be an issue in patients who received cisplatin and carboplatin as part of their chemotherapy, as well as those who got radiation to the head. And dental late effects. Any child who received almost any chemotherapy is at risk for a variety of dental problems, including enamel problems and dental problems, and problems with development of their secondary or adult dentition. Lung function, pulmonary complications can be a problem in patients who receive bleomycin, patients who receive pulmonary radiation, and patients who receive surgery to the chest. Hepatobiliary side effects can be a problem. A lot of chemotherapies cause acute effects on the liver. Most of those don't cause late effects and tend to improve over time. But certain problems like hepatic veno-occlusive disease, now called sinusoidal obstructive syndrome, can cause tremendous and devastating late effects like ascites and cirrhosis and fibrosis and lead to liver failure. Renal toxicity in patients who had certain treatment exposures like, again, cisplatin, carboplatin, ifosfamide, patients who had renal tumors, obviously, who most of whom will have had a nephrectomy, maybe a partial nephrectomy, can be an important late effect. And effects on other aspects of the urinary system. In the bladder, in patients who receive cyclophosphamide, ifosfamide, or radiation to the bladder, can be at risk for hemorrhagic cystitis and other problems with the bladder. Moving on, and it's not fair to try to cover this topic in just a slide. I could give a whole talk or a series of talks on psychosocial problems. And in fact, most survivors are psychosocially well-adjusted, but they are twice as likely as their siblings to report having adverse mental health. They're at increased risk for depression in a lot of series, although not all series actually report increased depression, as well as for anxiety, PTSD, and suicidal ideation. They're at risk for delayed psychosocial development and in general have a lower rate of marriage and cohabitation, of college graduation, and of full-time employment. It's interesting, this has been looked at, that survivors of childhood cancer report a similar or even slightly lower rate of risky behaviors like smoking and alcohol and substance abuse, which is sort of encouraging to see. There are a number of not surprising kind of intuitive risk factors for those survivors who are more likely to have poor psychosocial outcomes, and it includes patients who had a CNS tumor and who received cranial radiation. This is often the same group. And also those patients that I mentioned, the ones who do have the more significant medical chronic disease and physical limitations as a result of their treatment. Survivors of ALL who were treated even without radiation also do appear to be at increased risk for ADHD and problems with learning, with executive functioning and processing speed. As a result, we think of intrathecal chemotherapy. Again, even in the absence of radiation, but if you add radiation, those who did receive radiation, those risks go up dramatically. So it's important to think about the individual risk factors that an individual patient had, because not all survivors are at equal risk for all these different categories of late effects, as I started to mention. So the type of cancer a patient had is going to determine the type of treatment exposures that they received. And so we need to think about these things as we look at survivors, the type of chemotherapy a patient had, what agents they got, and what doses of those agents. In the case, for example, of alkylating agents or anthracyclines, as we start to calculate or estimate the risk that they're at for cardiovascular complications, for example, as well as the route of administration, intrathecal versus IV. Radiation therapy, it's important to consider what region of the body was radiated, the dose of radiation they received, and the modality as we look at newer modalities like proton therapy versus external beam therapy versus not very commonly used in pediatrics, things like brachytherapy. Patients who received a stem cell transplantation, looking at the source, there's a difference, of course, between autologous stem cell transplant, given as a means of escalating the chemotherapy dose a patient receives, versus allogeneic stem cell transplant from a bone marrow or a cord blood source. And whether these patients did or did not have graft versus host disease is going to affect the range of late effects that they're at risk for, as well as, of course, the conditioning regimen they had, whether it included radiation or not. Cancer surgeries, the type of surgery and location will, of course, affect the risk of late effects. And an important thing to look at is blood product exposure. Patients who received a large total volume of red blood cell transfusions may be at risk for transfusional iron overload, and this is an important thing to think about in our survivors as well, especially those who had a transplant or those who are treated for acute myeloblastic leukemia, who will have needed a lot of transfusions over time. The age is important to consider, the age at diagnosis, and also the age at follow-up and how long it's been over time, because a lot of these late effects will not show up. We don't expect them to show up in the early years after treatment, and not until maybe decades after treatment has ended. The patient's sex, of course, is important to consider. Certain late effects, infertility, as I mentioned earlier, and as was mentioned in that comment, the patient's genetics, the family history. Do they have an underlying cancer predisposition syndrome? And what genetic factors are there that determine who's going to get a cardiovascular complication, for example, or osteonecrosis, given a similar treatment exposure, and who isn't going to get that? This is a field ripe for research, and we're just beginning to start to understand some of these things, and we don't have a lot of good answers just yet. So with all of that said, and all of that kind of gloomy news, why does long-term follow-up matter? Why do we care, and why do we need to provide sort of specialized long-term follow-up care for these patients? It's important for a number of reasons, because as I hope I just convinced you, the medical and psychosocial late effects of for these patients are significant. But maybe if we're following them closely, we have an opportunity to identify these problems early, and that will give us an opportunity to intervene before there are clinical signs, for example, of heart failure, or also before some of the psychosocial late effects get to be problematic. And maybe if we identify learning disabilities early, we can institute an IEP in school and get patients the help that they need. Patients need to understand the risks because they may have no problems or symptoms for years and think that they're fine. They need to avoid additional risks like smoking. We need to look out for things like hypertension in the setting of renal disease or renal risk factors. And patients need to know when something is wrong and to say something and to bring it to attention. Patients need to know their history. They need to be able to bring this history to their doctor. The details of the cancer treatment are complex, and patients can't necessarily be expected to understand or remember all of these details, but the details matter and need to be able to be communicated because the risk of particular late effects depends on the treatment history, but it can be difficult to keep track of the medical records. It's important because healthcare providers need the information. As I said, we need to know the details of the treatment history and the diagnosis in order to calculate and understand the current and the potential late effects. So that means there needs to be communication between the pediatric oncologist and the primary care provider and other specialists who may be involved in the patient's care. And we all need more research. Cancer treatment is constantly evolving, and I showed you the difference over time in the late effects in the more recently treated patients, but we're seeing an explosion now in the different types of chemotherapy treatments that are evolving. And what risks are patients going to be at for late effects after exposure to some of the newer cellular therapeutics, some of the newer evolving targeted agents, tyrosine kinase inhibitors and others? We don't know because they haven't been around long enough. And it's going to take decades for us to really understand those. And our recommendations need to change in order to reflect that new knowledge. And another important factor for childhood cancer survivors is that kids grow up. And they're all of them going to need at some point to transition their care from the pediatric to the adult healthcare setting. And they're going to need to take increasing responsibility for their own personal health. So for all of these reasons, in 2003, the Institute of Medicine published a report that served as kind of a call to arms for the creation of survivorship clinics that weren't always necessarily in existence across the board. They issued a set of recommendations to improve the care and quality of life for childhood cancer survivors. In parallel, they issued a similar set of recommendations for adult cancer survivors. They wanted the development of evidence-based clinical practice guidelines and to define some standards, and called for the establishment of programs in all pediatric oncology centers, and then to evaluate different models of care, to improve awareness among survivors and their families, to improve education for providers, and to dedicate government and private resources to ensure access to care for those survivors. And this is still an area where we haven't really met the, we haven't really lived up to those expectations. The goals of long-term follow-up fall into some of these broad categories: education for the patient and family, and also for healthcare providers; surveillance for screening tests when appropriate, and doing a comprehensive history and physical; coordination of care among providers; documentation and transition of care when necessary. All of those three broad categories should result in these two important documents that we call a cancer treatment summary and a survivor care plan. This is where you were, what you were diagnosed with, and how you were treated, and this is where you're going, what you're at risk for, and what you're going to do about it. All of this needs to be sort of written down and communicated to the patient and their family and to the providers in a way that's accessible. We also want to provide support with psychosocial services and financial and insurance issues, and we always want to continue contributing to research. Unfortunately, in spite of this, not all patients are getting equal access to the long-term follow-up care that they need. Less than half of adult survivors in one study reported having had any form of cancer-related follow-up in the last 2 years. So we're not really there yet, and the risk factors are the ones you might expect: lack of insurance, distance, just kind of complacency among survivors who may feel perfectly fine and feel that this isn't really a high priority for them. But we need to do it. I'm not going to go through details of this slide, but suffice it to say there's a lot of different models. There's a lot of different ways of providing survivorship care, and different centers will set up different types of program depending on the context. A freestanding children's hospital like mine is going to be different perhaps than a cancer center like MD Anderson or Sloan Kettering or something, where they have a pediatric cancer center and an adult cancer center, and they're maybe more integrated and all together. That's not to say that one model is better than another, but it's all context dependent, and it's going to depend. And it's going to depend too on the community resources and where the patients live, how far they are from access to survivorship care. All long-term follow-up programs should be multidisciplinary. They should include, at a minimum, availability of a psychologist, a social worker, ideally research and nursing staff, and other things when available and appropriate, like a nutritionist, maybe a geneticist, maybe an endocrinologist, and others depending on the types of survivors that they're following. The goals of treatment I mentioned in that last slide. We want to do surveillance and manage late effects. We want to provide education, we want to provide support, and we want to contribute to research. And all patients should receive a comprehensive treatment summary and a survivor care plan. To help us implement this, the Children's Oncology Group, in response to that IOM report, later that same year, went ahead and ran with it, and they issued their first set of guidelines that are evidence-based graded recommendations grouped by treatment exposure and by organ system. And these were designed for survivors of for at least 2-year survivors for surveillance of late effects. The most recent version, these are continually being updated, was version 5. It just came out in November of 2018. It includes this helpful set of health links that is written in layperson terms for the patient and for family education, grouped by and targeted for particular late effects depending on what that patient is at risk for. And these are publicly available at this website. Here's a sample of just one page out of this very long set of guidelines, just to give you a sense of what it looks like. So this is a page out of the chemotherapy as opposed to the radiation section or the surgery section, looking at anthracycline treatment, that is daunorubicin, doxorubicin, epirubicin, etc. And it gives you a dose conversion here because not all of them are equally cardiotoxic. So you can calculate based on the patient's cumulative dose to sort of equate it to the doxorubicin kind of standard. This page is focused on cardiac toxicity, and it shows you here what you should ask for in your periodic evaluation, what to focus on in a physical exam, and what screening recommendations, in this case an echocardiogram, and how frequently to do it based on a combination of did they get radiation to the chest, yes or no, and if so, how much, and what the total dose of anthracycline was in doxorubicin equivalents, and how often to get an echocardiogram, whether they need none of them at all, whether they should get them every 2 years or whether they should get them every 5 years. And this is the newest recommendation. It's different than version 4, which had us do them as often as every 1 year. Now it's only as often as every 2 years. So these recommendations are changing over time, and we need to update our patients as the recommendations evolve. Another useful resource that was developed in collaboration with the COG and Texas Children's Hospital is this website called Passport for Care. It's got two sides to it. One is for the providers to help us plug in the information, and it spits out a really nice, organized, comprehensive treatment summary and a survivor care plan. So it creates these documents for us, individualized for the patient, based on the important treatment exposures and the cumulative doses that we plug in. But there's a survivor website too, where they can log in a secure way and access their information. If they're away, they lose the papers, they go to a new doctor, they want to print them and have access to them. So this is a terrific resource that we use in our center to do what we do. So what do we do in our center? Just as an example. So in our clinic, all the patients who come through will get a history and physical. We have a multidisciplinary team that includes a couple of oncologists like myself, my colleague Dr. Fusner. We have a social worker, a psychologist, a nutritionist, and an endocrinologist in clinic to evaluate the patient and see them as appropriate and spend time with them. We provide education. We spend a lot of time. These are long clinic visits because we go over in a lot of detail the late effects and the history and all of this stuff, and give them a printed out and then access to Passport for Care, the treatment summary and a survivor care plan. We order the screening tests that are needed and we review them with the patient. We provide coordination of care, referrals to specialists as needed, and follow-up. And we contribute and are involved in research. We focus on adolescent and young adult patients who are ready to transition. Because we have limited resources, we do these clinics once or twice a month. And so we've tended to focus our priorities on the older patients who are further away, who are longer, who've had longer time completed since the end of treatment, and are ready to make a transition away from, sort of graduate from pediatric oncology and move on to follow up with their primary care provider. So generally, we see them once as a consultative service in the survivorship program. Now, they're all getting long-term follow-up in the meantime through their primary care, through their primary oncologist. But at some point, their primary goes, you know, this patient is 20, they're 8 years or 10 years or whatever from the end of treatment. It's time to move on. We're going to run you through the survivorship program and give you all of this detail and wrap everything up in a neat package so that the primary care provider and the patient has all the information they need to know to take it from here, and we're going to pass the torch to them. That's our job. Now, not all of our patients are going to do that. Some are going to be younger. Maybe they were diagnosed when they were 1 or less than 1, and it's 10 years from treatment, but they're still only 10 or 11. And we're going to keep following them in pediatric oncology because we want to see them, and they're still pediatric and it's appropriate. And maybe if they had a neuroblastoma, they're still at risk for late effects, and we want to keep watching them. But we may still provide them this information, and then they've been through the process and they're ready to pass. We're ready to pass the torch when the time comes. What do the primary care doctors need to know? What's the role of primary care in these survivors? Well, as I hope I convinced you, primary care is essential to proper follow-up of survivors wherever they live and whatever the setup for the particular long-term follow-up clinic. Patients may need to transition, as I mentioned, from pediatrics to the adult-oriented healthcare. At some point, the pediatrician is going to also say it's time to move on. All these survivors ought to get at least an annual healthcare maintenance visit, which is sometimes a difficult sell. It's hard to convince adolescents and young adults who feel fine and are otherwise healthy to take time out of their busy schedules with school and work to come in when they feel fine and actually go see the patient. So we try to convince them that, yeah, it's worth it, and yeah, it's important, because we do need to look out for these things. It's important to note that the history and physical alone is adequate screening for most of the potential late effects. So there's actually not all that many screening tests, laboratory tests, and imaging studies that are really necessary. So a targeted history and physical based on the patient's actual exposures and risks is sufficient for most things, as should have been laid out in a patient's survivor care plan. Other things are going to be based on their exposure. So how often, for example, you need an echocardiogram, every 2 to 5 years, or perhaps not at all, depending on the exposure. Some patients, for another example, may need thyroid function checked regularly in patients who got radiation to the neck or cranial radiation. Some patients, as they get older, may need enhanced or earlier onset of breast or colon cancer screening, so those who got chest and abdominal radiation, respectively. These are just a few examples. And then primary care doctors also may need to provide coordination of care to have communicated and get these survivor care plans from the patient or from the pediatric oncologist, and then provide referrals and coordination with any other subspecialists who may be needed. I'm going to pause there because I ran a little bit late and it's 9 o'clock now. I prepared a few case studies to go over examples, but I don't want to go too far over time, and I want to leave a couple minutes at least for questions.
Excellent, thank you. Yeah, we'll open it up right now. So there is already a question that came in. Do you teach the patients how to self-advocate when they go through the survivorship clinic?
Yeah, absolutely. And all of us do that from our own sort of respective perspectives. The oncologists and the social workers and the psychologists with how to advocate in sort of those different arenas. It's important. A lot of patients will have had their insurance lapse, or they're going to age out of their insurance, and we certainly make a point of emphasizing that it's important not to have gaps in insurance. We still don't know in this climate what's going to happen with the Affordable Care Act, and whether pre-existing conditions will sort of come back as an exclusionary thing to prevent patients from ever getting insured again with a history of childhood cancer. So it's important to, so we emphasize this important point. This is one element of the education that we provide.
Okay, fairly lengthy comment here from Dr. Robin Palmer. Hereditary cancer in peds setting is under-recognized. For example, live Fraumeni syndrome is way under-recognized, and our picture or understanding of LFS is expanding. It is likely that LFS is more common than previously thought. 50% of LFS develop cancer by 30 years, and 1/3 develop multiple cancers over lifetime. And identification of LFS has ramifications for treatment of cancer. Increased radiation sensitivity and chemotherapy resistance. Insurance is increasing reimbursing for genetic testing, but taking a family history is key to identifying a hereditary cancer such as LFS. Although some hereditary cancers can occur due to de novo mutation, FHX can be, sorry, I don't know what FHX is.
Family history.
Family history, okay. Family history can be obtained by having the patient or family complete a family history form and or referral to a genetic counselor to assess hereditary cancer risk. Also, identification of hereditary cancer has big-time ramifications for risk of cancer for other family members, particularly patients' offspring.
So I agree with all of that, and I couldn't have said it better. And had I had more time, I would have liked to delve into that a little bit more. I will say that we we had an integrated medical geneticist in our survivorship program here in Oakland for years to assist us in doing that screening program. That person moved, and we're still trying to get her back or to replace her. But for now, as we take our own family histories, and we're careful to do so, when appropriate, we will refer patients for additional testing, if it wasn't already done, based on the diagnosis and family history that we already knew about, to the cancer genetics program just across the bay at UCSF, where they have a very robust program for doing all of that testing. We often run into a lot of insurance barriers, though. It's a frustrating wall to bang our head against, where we know what we want to do, and in some cases we're sort of prevented from doing it. But we do it whenever we can and whenever appropriate. So point well taken. I'm glad that that point was brought up.
Okay, any other questions or comments before we finish up for the day? I've got a few announcements I'd like to share. So the first is that for anyone who's interested in more pediatric related topics, we do have a once a month complex pediatrics echo clinic that meets on the second Fridays at noon. It's the same Zoom link and everything, so if you'd like to join that one, we'd be happy to have you. Our next session for this Cancer Survivorship Echo is March 8th, and we'll be talking about advanced directives and PULSed. And then I'm sharing the screen right now. Bridget, do you want to talk about the summit?
I can unmute myself, yes. I want to take a moment to thank Dr. Robert Raphael for that amazing and informative presentation. Thank you so much for taking the time to educate us. It was great. So I hope people are going to be able to watch this because it will be posted online as well. But in regards to the Nevada Cancer Control Summit, I just want to say to mark your calendars. It will be coming up September 16th. 2019. It will be held here in Reno this year at Whitney Peak. So the Nevada Cancer Control Summit, it's a one-day statewide conference featuring presentations on targeted topics across the cancer spectrum. So you can go to our website. We also have really wonderful tools for providers to access to help educate their patients as well as themselves. And yeah, thank you so much everyone for attending.
Yeah, absolutely. Thank you, Dr. Raphael. Thank you for those of you who joined us and stuck through today. So as I mentioned, we'll be back March 8th. Hope to see you then. Thanks, everyone.
Thank you.